Assalamu alaikum and welcome to the Medical Black Book. Our today's topic is lymphatic disorder. The first topic which we are going to discuss in this chapter is lymphedema. Lymphedema is a condition of localized fluid retention and tissue swelling caused by compromise in the lymphatic system. The normal lymphatic system function is to transport interstitial fluid to the bloodstream. So if there's a compromise, there would be accumulation of the fluid in the interstitial space, hence the feet would look, or any extremity where this fluid accumulates would look edematous. Lymphedema has a primary cause or a secondary cause. In a primary cause, there is genetic problem, such as either it could be familial, such as known Mallory type 1, in which there is abnormality of VEGRF on chromosome number 5, which cause Brownie lymphedema of both limbs. This condition develops at birth or either before puberty, while Meek syndrome affects both limbs and sometimes arms, and this develops before puberty or even in the middle age, which is 50 years. In secondary lymphedema, the first primary cause is filariasis. This is basically a parasitic infection caused by Roturia bancrofti. This organism lodges up into the lymph nodes and causes inflammation, which results in flow obstruction. In the lambs, we can find this immature parasite. Add blood at the night, and in the lymph node, we can find mature parasite. This parasite has a complement fixation, and this raises the eosinophils in the blood. It can be killed by diethyl carbamazine. Our next cause is endemic elephantiasis. This is caused in patients who are living on alkaline volcanic rocks. This volcanic rocks causes destruction of the peripheral lymphatics by particles of silica seen in the macrophages, which is drained in the lymph nodes, and hence in these patients are likely to have plantar edema in early childhood. In bacterial, what this does is bacteria blocks the lymphatic system by acute inflammation such as TB of the limbs, whereas in malignancy and treatment, what happens is in the treatment of breast carcinoma or lymphoma or malignancy of any pelvic organ or capsuloid sarcoma, these malignant cells basically accumulate in the lymph nodes, hence causing it to block. In trauma, because of disuse or venous thrombosis, lymphatic injury results. This can also result from burns or destruction by degloving injury. Now, how do we investigate such lymphedema? We can investigate lymphedema by first routine tests. Routine tests include CBC, urea, electrolyte, creatinine, C-reactive proteins, liver functions, thyroid functions, etc. You have to rule everything out before coming to this conclusion. Then we have Lymphangiography, which can be done either directly or indirectly. This is a picture showing Lymphangiography. In the direct one, what we do is we inject a contrast medium into the peripheral lymphatic vessels, then radiologically examine the nodes. By this, if there is any sort of blockage, we can identify it. Whereas in indirect lymphangiography, what we use an intradermal injection of water-soluble, non-ionic contrast in the web space from which the lymphatics take it up. So one thing is we directly injected it into the lymphatic system to assess an obstruction, and the second, the indirect one, we injected the dye in a web space. Now our third one is isotope lymphoscintigraphy. In this procedure, technetium-labeled protein or colloid particles are injected into the interdigital web space, and the radiograph is taken with the help of a gamma camera. These are images taken by the help of gamma camera. In a normal person, you can see there are a variable amount of lymph nodes, and this is showing the pathway. In a Mallory disease, this dye is injected up to this position, and there is no pathway is seen. Whereas lymphedema, dysgenesis syndrome, this shows an edematous foot and the pathways through which the lymph nodes are being drained. Similarly, a proximal obstruction, which you can see here. The the dye is basically what it is being accumulated at these positions, and it is not drained from here. Now, the pathological examination. In this, we include fine needle aspiration, needle core biopsy, or surgical excision to rule out any sort of malignancy or any other conditions that could have caused lymphedema of the limb. The next is limb volume measurement. Limb volume measurement helps us to determine severity. This is what we do in this is we compare the affected side with the unaffected side, and we measure both of these lengths in millimeter. Now, how do you manage lymphedema? First of all, what you need to do is to relieve pain. Now, as you know, this can be caused due to two things: cancerous state or a non-cancerous cause. In a cancerous state, that the swelling is from radiation, from surgery, either from nerves involving the brachial plexus or bones because of the secondary deposits. So in order to cure a cancerous state causing lymphedema, we need to give patient opioids, analgesics, muscle relaxants, antidepressants, nerve block, and physiotherapy. Whereas non-cancerous cause, what we do is we control the swelling. Now, controlling of swelling by physiotherapy or any other procedure, that will be given in the subsequent next slide. And we also need to prevent complication due to prolonged stasis. Control of swelling. Control of swelling is by bed rest, elevating and bandaging, compressing garments, massage, exercise, decongestive lymphoedema therapy. In decongestive lymphoedema therapy, this comprises of two phases. The first phase is short course with the therapist and maintenance care by self-care. The second phase is an intensive phase and comprises of skin care, manual lymphatic drainage, multiple lymphoedema bandaging, and exercise. Our third treatment is through surgery. If all of the medical treatment and the controlled swelling treatment stops to function, we can tell the patient to undergo surgery. In this, the first procedure is the bypass procedure. In the bypass procedure, we have further divided into four procedures known as the Giles procedure, Nebula Wurtz, Kinmonth, and lymphovenular. To remember this, remember a long foot which has on the upper end gills, hence the gills procedure. In this end, you can see an alien, Nebula Wurtz, a smart alien. In this picture, you can see a person trying to remember which month could it be, Kinmonth. And here you can see the arrows. This showing the lymphatic pathway, and this showing the veins. So if you want to connect or anastomose the lymphatic pathway to the venular pathway, it will be termed as lymphovenular anastomosis. So what does the Giles procedure does is it connects the lymphatics with the nomental or a skin bridge. In Nebula Wurtz, it is the anastomosis with a vein. In Kinmonth, it is an ileal and mucosal match. After this procedure fails, we can move towards liposuction. It is basically a reduction procedure, as you can see here. And the third is limb reduction. This is done when the mobility is affected. It does not restore the limb to the normal shape because it is associated with a lot of scarring. The common operation done in this is limb reduction surgery are cyst-trunk operation, Homan operation, and Thompson operation, and Charles operation. Cyst-trunk operation, do not confuse it with thyroglossal cyst operation. It is quite different from this one. In this, what happens is a wedge of skin and subcutaneous tissue are excised and wound is closed primarily, most commonly used to reduce girth of the thigh. Then we have the Homan procedure. In this, the skin flaps are elevated, as you can see, and the subcutaneous tissue is excised, and the skin flap trimmed and closed. Usually stage produced with lateral and medial separation by 3 to 6 months to avoid necrosis. Mostly, this is done for the calf. In the Thompson procedure, what we do is we do denuding of skin flap, and what we do is then suture the deep fascia. We remove the subcutaneous tissue, denude the skin flap, and attach it to the. After removing it, we need to to the deep fascia. We attach it to the deep fascia and simply by burying it. We establish connection between superficial and deep system hence. But there is a complication. This can lead to pylonitis formation, pylonitis sinus formation. In the CHARS procedure, what we do is excise all of the skin and subcutaneous tissue down to deep fascia, and then we later on cover it by slip grafts or skin grafts from the excised skin. The girth can be reduced, but it is unsatisfactory cosmetic results. Now, other conditions that mimic lymphedema are factitious lymphedema, which are seen in psychotic patients using tourniquets or hysterical disuse in patients. Then we have, due to immobility, this can result in generalized or localized edema. And in some, lymphedema happens. This is the bilateral symmetrical enlargement of the legs, sometimes to the lower half of the body due to abnormal fat deposition.